All right, welcome everyone. Good evening to those on the East Coast and late afternoon to those logging in from the West Coast. Thank you so much for taking the time to join us for this month's installment of the Resident Education Club presented to you by the Society of Skeletal Radiology. My name is Tony Wong from Columbia University in New York, and I will be your moderator for this session. Our speaker today is Dr. Kara Gaetke-Udager from the University of Michigan. Dr. Gaetke-Udager is currently an associate professor of radiology there. She completed her undergraduate degree at Yale University and graduated from the University of Michigan Medical School in 2008. She did her radiology residency, her MSK fellowship, and also an abdominal imaging fellowship, all at the University of Michigan. She joined the faculty there in 2015. She has been the program director of the residency program there since 2017 and the division director of the musculoskeletal section since 2021. Today's topic is the foot, and Dr. Gaetke-Udager will be speaking about interesting foot cases. Throughout the talk, if you have any questions, please put them in the Q&A chat, and we will either get to them during the lecture or afterwards. So Kara, really appreciate you being here, really excited to hear the talk, and I'll turn the floor over to you to get started.
Great. Thank you so much, Tony, for that really nice introduction. And thanks to the SSR for having me tonight. I'm really excited to be here. It's a great honor. And I'm looking forward to showing you guys some interesting foot cases. So let's get started. So I know there might be a mix of residents out there tonight. So some of these cases are going to be kind of bread and butter stuff that I think everybody should know and be comfortable with. And some of them are going to be a little more unusual. So I hope that it kind of keeps you guys on your toes. I'm going to talk through some of the imaging findings. I know it's a little hard to be interactive in this kind of format, but if you want, as I'm showing images, to put things in the Q&A for an answer, you can definitely do that. And I'd love to hear your thoughts as we go along. I have no disclosures. So we're going to start out with the first case. This is a 54-year-old, and the history is rule out osteo, which you guys see all the time. And I'm leading off with this case. I know it's not everybody's favorite topic, but this is something you guys see a lot, and something that the first thing I usually want residents to know when they're on call. So we're going to start out like we always do with radiographs of the foot. I know it may be a little harder to see than on your workstation, but I'm going to talk you through what I see here. So we see an osteopenic foot. And to me, I see in the first metatarsal head a little bit of maybe some erosion and irregularity along this lateral aspect of the metatarsal head here. And also kind of a subtle finding, maybe some lucency in the first metatarsal head. So we're reading this radiograph. We think maybe there's some changes. They're a little bit subtle. The clinical team's worried about osteomyelitis, and we're going to go on to an MRI. So these are coronal sequences. We have T1 weighted on the left of the screen, fluid sensitive in the middle there with fat saturation, and then post contrast on the right. And so this is kind of what we expect when we're hearing this history. We see very nicely a plantar ulcer under the first metatarsal head on all these images. Underlying that in the bone, where we thought we maybe saw some osseous changes, we see low signal on T1 weighted images like marrow replacement. We see some high marrow signal on the T2 weighted images, or maybe some marrow edema, and then post-contrast enhancement in that first metatarsal head. So this should be a slam dunk for you guys. This is osteomyelitis of the first metatarsal, and it so nicely demonstrates what we're always looking for, which is a soft tissue tract leading from the ulcer down to the underlying bone, and then we're looking for signal abnormality in the bone. That's what we see on the radiographs too. So you should see this case, and this should be easy. I think the thing I want to point out here is that we're looking for that ulcer to show us exactly where the osteomyelitis is going. So if you can find that ulcer, spend that extra 30 seconds looking through the medical record to see where the ulcer is if you can't see it. That's really going to help you to understand where you're looking. And then we're looking for signal abnormality in the underlying bone. So this one should be straightforward. Everybody gets this case. The reason I'm showing this at all is I want to also talk about the subtle parts of this type of diagnosis. So I'm going to go on to another case, and I'm asking you guys here, do you see osteomyelitis here? So this is a case where there's an ulcer on the tip of the big toe here. You can see it, I think, on these images. We're seeing signal abnormality in the underlying subcutaneous tissues. So we see edema here on the fluid sensitive sequence. We see post-contrast enhancement in that subcutaneous tissue. So we're thinking there's some cellulitis. We're looking for osteomyelitis, and we look in the bone marrow underlying this ulcer on the T1, the fluid sensitive, and the post-contrast. I would argue we don't see any marrow signal changes under that ulcer. So even though there's cellulitis over top of it, we're going to say no, I think, on this case. There's no osteomyelitis here. And we can pretty confidently say that. This is a good example of one of those cases. What about this case? So I pulled this out because it's a good example of real life. Sometimes we don't have all the sequences. Sometimes there's motion artifact. The patients are uncomfortable. Sometimes we don't get all the way to the post-contrast and we just don't have those sequences. So can we still make a decision here? So I would argue that we can, and I'll walk you through this one. So this is a coronal image of the foot, T1 weighted and like a stir sequence here. And there's a soft tissue ulcer over the fifth metatarsal head on these images. So we know we're looking to the underlying bone. We're looking for osteomyelitis. And I think sometimes in residency, we have a tendency to think like if we see that T1 low signal, the marrow replacement, it's osteomyelitis. And if we don't, it's not. It's a little more complicated than that. And this is a good example of that. We know that there's an ulcer right over this metatarsal head, and we see marrow edema in the underlying bone. We probably aren't going to say that we see marrow replacement on this image. This fat on the T1 weighted image looks pretty clean. So what do we do with that? We see the ulcer there. We see some marrow edema. We don't have the post-contrast sequence. For this type of case, we would say that we see some marrow signal changes under that ulcer because we know that's the spot that's probably going to be abnormal. This could be just reactive changes from that ulcer sitting right on top of it. Or it could be a developing infection. We don't see the marrow replacement yet, but we see some signal change. So we're going to hedge here. We're going to say we're not sure, but maybe this could be developing osteomyelitis, or some people would call this osteitis. I think this is a good example of that and something that I want to make sure you guys are saying when you're on call and looking at these cases. And then this is kind of like another step down the line. This is now we have cellulitis and subcutaneous signal changes over the fifth metatarsal here laterally with an ulcer. And we do kind of start to see this patchy marrow edema right underlying that, patchy marrow signal in the T1 and some marrow edema. So we're going to say, yeah, this really looks like developing osteomyelitis. We're starting to see that marrow replacement happening. So teaching points on this case, always look for the ulcer, always try to figure out where it is and look right underneath it. That's your guide. If you see edema or enhancement under the ulcer, but you're not seeing marrow replacement, you can still say that that might be developing infection. You got to make sure you make that distinction. And then if you do see changes on the T1, you're going to say, yeah, that looks like marrow replacement. And now I feel more certain about the diagnosis. No, that's straightforward for you guys. But I think if you understand that really well, you're going to be able to read these cases with a lot of confidence. So case 2, we're going to go one more step down the line. This can be really challenging. So this is a 62-year-old with diabetes, rule out osteo. Here's the radiograph. And this one's a little more complex than that last one. We look at this foot and we see, first of all, probably some absent bone here in the fifth metatarsal. We look at the midfoot and it looks kind of like a mess. We see definitely some degenerative changes. It looks like maybe there's some lucency and erosion here. There's maybe fracture even. This whole midfoot is collapsed. So we're thinking maybe there's some Charcot-like changes in this midfoot, and it's just really looking like there's a lot going on. They want us to rule out osteo. So how are we going to do that? Because we see so much happening on this radiograph, and probably we're going to see a lot happening in the MRI. Here it is. We see these are coronal weighted or coronal sequences. We have T1 weighted stir here, and then post-contrast on the screen, right? And the way that you do this, so the vast majority of the time, osteomyelitis is coming from contiguous spread from an ulcer in a diabetic foot. So we know almost all the time we're going to look for that ulcer and look right underneath it to see if there's osteo. Very rarely you can have osteo coming from hematogenous spread, but it's going to be like the minority of cases, and we're going to want to look first for an ulcer in a diabetic foot. So even if there's background Charcot arthropathy or other degenerative changes, we're still looking for that ulcer. And when we see the ulcer like we do here on the foot, it's plantar ulcer. We see that tract, there's a little bit of non-enhancement underlying it, and then enhancement of all this bone underneath it, and then edema, and we see marrow replacement. We know that that's osteomyelitis, maybe superimposed on top of this Charcot arthropathy. So that can be really tough, I think, to distinguish, especially in the middle of the night. You guys are trying to figure out what's what. With Charcot changes, it can look a lot like osteomyelitis signal changes. Look for the ulcer, go back to that, and look right underneath it and see if you can figure out if that's coming in from the outside, because usually it will be, and that will guide your way. This is that same patient. I'm just giving you another look, but you can see how much abnormality there is in this midfoot. But finding the ulcer and seeing if there's signal abnormality underneath it, that's going to give you the answer. So we're going to say there's acute osteomyelitis here, and then we're going to describe all the other changes. The other question I think that comes up a lot with residents when you see these kinds of cases overnight or even daytime in the reading room, we're looking at these and we'll say, why are we even getting this? We know there's osteomyelitis. They're probing to bone. You know, the providers are talking about probing to bone. we are looking often for the extent. And so if they're going to do surgical management for some of these patients, they might know there's osteomyelitis because they're probing to bone, but they want to know how much of the how much of the bone and the bone marrow is involved, how much of the foot is involved if they're going to think about amputation or something like that. So we're going to be descriptive of that and try to include all the areas we think are abnormal. That can be tougher when you have background Charcot arthropathy or other changes, but you're going to do your best and try to describe where you're seeing those areas of signal abnormality. All right, so teaching points for this kind of case where you're looking for osteo in a Charcot arthropathy patient. You're going to, again, look for the ulcer, describe the extent, and then realize that you can have this osteomyelitis superimposed. So you're going to try to kind of figure out where the margin is there. All right, case 3. So we're moving in a little bit different direction here. This is a 65-year-old patient, history of morphia profunda with chronic steroid use. This patient has fifth toe pain, redness and swelling, but no ulcer. And they've been on multiple courses of antibiotics for a few months. So they're suspicious this person has an infection. The antibiotics aren't really clearing it up. There's no ulcer, so we're not going to have that to help us. So these radiographs, we see abnormality in the fifth metatarsal. There is lucency kind of all throughout most of this metatarsal shaft, and some of this looks a little lacier and expansile, like it's maybe been there for a while and kind of slow moving. And then we see a little bit more destruction here distally. So there's cortical destruction. There's just a little bit of this metatarsal head remaining. So we definitely have some abnormality in the fifth metatarsal, and it looks like it's an aggressive process, but portions of it may be a little bit more expansile. Here are coronal images. These are T1 and STIR. And we don't have post-contrast images here, but you can see the abnormality. There's this low signal material that's replacing essentially the distal fifth metatarsal. There's high signal here on the fluid sensitive sequence. And we can see where that radiographic appearance came from. So all this bone has been replaced. There's some sort of process here that's relatively aggressive, that's going all through the bone. It looks like it may be going out in the soft tissues. I'm going to show you some sagittal images here. These are all post-contrast images. And you can see there's this kind of diffuse process, a little bit infiltrative all through the soft tissues. And it's involving the bone, it's involving the soft tissues. And I included a couple of these images to show you there is involvement and enhancement here in the tendons as well. So we're looking here, this is a tendon that actually has this enhancement and material all throughout it. So as opposed to these other cases we looked at where we're seeing an ulcer and we're seeing changes right underneath it, this is something going on in the bone and in the soft tissues. It's aggressive. So when we think about aggressive processes, we think about neoplasm, we think about infection. They're suspicious of infection here. So this was, we actually biopsied this metatarsal, and this came back as a mycobacterial infection. So in contrast to the cases we saw before, where everything was destructive and it looked like the bone was eaten away, this was a little bit more of a slow growing process. So we still have some, if we go back here to the radiograph, we still have some of this metatarsal left. This is somewhat preserving the joint here. There's fluid here and there's soft tissue abnormality, but it's a little bit preserving the joint. So it's a little bit slower growing than your normal pyogenic infection. So this was kind of an interesting case. We don't see this every day. So slower progression in a mycobacterial infection, the preservation of the joint space until a little bit later, and then the clinical history is really important here. So we knew the patient was immunocompromised and had been on steroids, and so that kind of added to our putting this case together. All right, case 4. This is another patient with toe pain and swelling, 55-year-old. Here are the radiographs. So these are sort of subtle changes, but if we look at, especially in this oblique view of the first metatarsal head, we see some erosion and lucency along this medial aspect here, maybe on the lateral aspect as well. There's kind of some lucency throughout this first metatarsal. Whoop, we're going to look here on we happen to have a CT on this patient. And the thing I want to point out, especially it's a little harder to see on the radiographs, is we have some faint calcifications here in the soft tissues along the medial aspect of the first metatarsal head. And then you can see erosive changes here around the metatarsal as well. And this is an MRI of the same patient. So these are coronal images, T1, fluid sensitive, and post-contrast on the right. And we see these erosions in the first metatarsal head, and then this soft tissue abnormality all around the first metatarsal head that's high signal in the fluid sensitive sequences of post-contrast enhancement. So putting this together, we have soft tissue calcifications, we have erosions, we have this kind of like soft tissue thickening and enhancement. This is just another view on the MRI. The coronal images kind of show these low signal foci. So this is that calcific material. So putting all these things together, we see this on the radiograph and the CT, the soft tissue calcification here. So this is a patient that has gout. We might, for seeing one joint involved, we're going to try to look at the pattern. So this is one joint. One thing that should come to mind always is infection. With this patient, we are not, clinically, they're not suspicious of infection. We have soft tissue calcifications that look like a gouty tophus. And then we have erosions in the first metatarsal head. We also know we can use our location here. We know that the first MTP joint tends to be a favorite spot to see changes of gout. So we're going to think about that. If we're seeing things more bilaterally and symmetrically, we might include an inflammatory arthropathy here. The tophus is something that kind of points more towards gout in this case. So we're kind of putting together what we know here to figure this out. This patient had elevated uric acid, so this was gout. And gout is one of those things where it's easy to forget about it when you haven't seen it in a while, something we always want to think about in the feet with all of our joint-related processes, and it can kind of do whatever it wants. We talk about different kinds of erosions when we see them. So there's marginal erosions with more like an inflammatory arthropathy like RA. There are central erosions that we see in erosive osteoarthritis. Gout has these periarticular erosions with overhanging edges, and it can kind of do whatever it wants. So you might see a lot of other types of erosions with gout. So gout does whatever it wants, and we see it in this location frequently. So when we're looking at this kind of case, we're trying to figure out erosions and what they are. We're going to locate the type of erosion. We're going to talk about the pattern, whether it's bilateral, whether it's symmetric, whether it's proximal or distal. And the other thing that to keep in mind with gout is that the osseous changes are often kind of late in the game. So if a patient has their, they may have symptoms early on, but really to get changes in the bone, we're going to be looking a few years more down the road since they started having this process, whether it was diagnosed or not. All right. So this case, case 5, this is an 18-year-old with plantar foot pain. They had a raised lesion on the bottom of their foot that had a hemorrhagic center. It was kind of red and it was bleeding all the time. And when you talk to the patient, they said they had been walking on the beach a while back, and ever since then they had this like wound on their foot. So we got a radiograph here. This is a lateral view. I would say it's kind of, to me, not showing a whole lot as far as what's going on with this lesion. The patient was seen in clinic and they had this raised lesion, and they ordered a CT. They thought that they had this raised lesion that was potentially something vascular. So a CTA was done. These are images from the CTA. So this is an arterial runoff. And the finding here is this little area of enhancement in the plantar aspect of the foot. And you can kind of see it here on these reformats. And so this was described and thought to be something enhancing. So they recommended this person see our outstanding interventional radiologist in clinic. So that's where the patient went next, and they pulled out their ultrasound machine. And this is an image that they were taking in clinic. And we don't see a whole lot of flow here on the Doppler image, but we do see this echogenic kind of irregular looking thing sitting in the plantar aspect of the foot, and some anechoic, probably fluid around it. So we found this and kind of wondered what was going on and thought maybe this looked a little bit suspicious for something like a foreign body. So then we got an MRI. So we have all the imaging here. We got these coronal images that show this open sore on the bottom of the foot, and underneath it there's this little tract and some sort of little area of signal abnormality underlying it, which is what we thought we saw in the ultrasound image, and then a little bit of enhancement of this tract on the post-contrast image. So this patient was taken a surgery, and it's a little blurry here, but this was the image we were given. So this little brown thing here was like a splinter, little piece of wood that was taken out of this area that corresponded pretty much exactly measurement-wise to what we saw in the imaging. So it's a foot conference. We have to show a foreign body case. So that's what this was. And the interesting thing about these, we do a fair amount of ultrasound in our institution, and these foreign body cases, they seem like they'd be easy to find all these things with ultrasound, and they're very difficult to find even when we think we know where they are. So keep that in mind when you're looking for these kinds of things. You might look on the MRI sometimes and it might be there and you just can't find it. it can be really challenging. So kind of be patient, talk to your providers about what they actually want you to do. But sometimes using multiple modalities is what you need to do to figure out whether it's there and what it is and what it looks like. So, try to be patient and do your best, because these can be really tricky to find, even though they seem simple. All right, case 6. This is a 41-year-old with forefoot pain and tingling. Here are the radiographs, and I'm going to bypass this by just saying I don't think there's a lot to see here. Doesn't look like any erosions or anything going on in the bones. So like I said, we like to do a lot of ultrasound in our institution. So they asked us to scan this foot and see if we could see anything. So with you guys probably already are smart and know when we're talking about forefoot pain and tingling, one of the suspected things is a Morton's neuroma. And we can see those on ultrasound sometimes. And so we often do those first at our institution. The differential here, some of the other things you can see in this area would be like an intermetatarsal bursa or something like that. So you'd be looking for fluid or things squishing in and out of these metatarsals. They're telling us here on the bottom, the fourth web space. And I'm going to play this video and see if I can show you guys. But here we're kind of squishing, trying to get something to click. And right there it does. So this is a really nice example. I think we do a lot of these cases looking for Morton neuroma, and it's really hard to find them. And we often don't see them. But I thought this one was a really nice example of actually seeing something in this fourth space really clunk up right there. And so they talk about the sonographic Mulder sign, where you're scanning and you squeeze the patient's forefoot and this Morton's neuroma pops and causes this clunk or a click that you can actually feel during the exam. And so this is a really nice example of that. So this was a Morton's neuroma. And I thought a good thing for you guys to see and remember. These can be really hard to find on MRI too. We often are looking at these little tiny areas of signal abnormality, trying to figure out whether we think it's a Morton neuroma. This I thought was a nice example to show you. This is a different patient, but I wanted you guys to see it because I thought it was a good example. We talk about a dumbbell shape, so kind of narrow in between the bone and then kind of spilling out on either side. These would look low signal in the T1 weighted images and then have some post-contrast enhancement. So this is just an example of what it would look like on MRI if you do see it. This is a really nice one. A lot of times they're smaller than this. So Morton's neuroma, dumbbell shaped. They can be tricky to see. And then we like ultrasound here, and it provides this nice dynamic evaluation. All right, case 7. This is one I want you guys to remember. I saw this actually when I was a fellow, and it's stuck with me ever since then. And I think really helped me to understand how to interpret some things when I'm looking at foot MRI. So this was the initial imaging. This patient was 35 and they had foot pain. They were an active person and they were looking for a stress fracture. So these are 2 of the images. So this was done just routinely. This was done as a non-contrast foot MRI. And the thing that I'll show you here, and it probably looks like nothing, is this little area, what looks like a little bit more fluid signal here along the dorsal midfoot. And you see it here on the coronal view as well. There's this little area of what looks like fluid. And when we're doing a lot of non-contrast studies in MSK, it's very easy to see this fluid signal stuff and kind of blow by it. And to think everything's a ganglion cyst or everything's part of some fluid in a tendon sheath or something like that. And so we have to be cautious and we have to go slow and make sure that we're seeing where it's coming from and what it is. And so as you guys know, with ganglion cysts, we're going to look for a multiloculated fluid signal structure, and we want it to connect to a joint. So we're going to look for those features, and especially if we don't have contrast on board, we're going to we want to make sure that we check those things off to see what this is. Already astute radiologist who read this case said, I don't really see that. This looks unilocular. Yes, it's fluid signal, but I don't see these other characteristics of a ganglion. So we called this in our report a focal area of fluid, maybe a bursa or a ganglion cyst, and we recommended ultrasound for further evaluation, thinking we needed to prove what this was. That didn't happen. So 18 months later, the patient comes back. They have a foot mass. The ultrasound was never done. I'm showing the prior here on the left of the screen, and now this is the current exam. So as you can see, this area that looked like kind of just this little area of fluid on the prior now looks like a bigger area. This is the coronal, these are the coronal images, and we see this low T1 intensity mass that has high signal here and diffuse post-contrast enhancement. So now we're more suspicious of this. This is now an enhancing solid mass that was biopsied. This is a synovial sarcoma. So I think this case, when I was a fellow, it made a big impression on me. And I want all of you guys to see it and remember it, because when we're looking at so many feet and so many areas, little areas of joint fluid and those kinds of things, we want to make sure that that we're we're following the details of what these things are. Yes, sometimes it's impossible to follow every little tiny piece of area of fluid in a foot, but when you see something that stands out to you and you're thinking it's a bursa or something like that, it's sometimes helpful to make sure. So this is a good reminder of that. So not all fluid signal structures on the non-contrast are cysts. And if you think it's atypical in some way, you can consider getting additional imaging, and you have to use your judgment, but it's something to remember when we're blowing through so many cases. So I thought a good example of that. Case 8. This is a 39-year-old. They've had a history of plantar fibromatosis that they said started when they were 17, so it's now 20 years later. They have a foot wound and bleeding. So this is not a subtle finding. These are the radiographs. This patient has, you can see soft tissue abnormality here on this frontal radiograph, but I think especially on the lateral, you see this big bulging area of soft tissue with what looks like some ossification in the middle of it. And then here's the MRI, and it's really, really striking, not like that last case. But we see this big exophytic or kind of pedunculated mass coming off the bottom of the foot. It's diffusely enhancing. And so we biopsied this, and the pathology came back as what's written on the bottom of the screen here, which is this some kind of benign mixed tumor. I happen to have a husband who's a pathologist, so I asked him for this conference what exactly this was, and all I could really understand was that it was basically a benign tumor. The reason for showing you this is just to show how to kind of, if you don't know exactly what it is and you don't know the histologic diagnosis, try to look at some of these imaging features. So this thing has been there for 20 years. It's slowly growing, it seems, but it's diffusely enhancing. And so a lot of MSK is this art of figuring out what to do next based on some limited information. We have a lot of masses that have a lot of the same signal characteristics. It's your job to know when to biopsy, when to recommend more imaging. And that's where this gets really tricky. And so this case, maybe not so tricky, but it's your job to know what the next step is with all of these things. And so for this one, we're obviously going to biopsy this. But we can use these features to tell us that we're guessing when we see this. This is probably going to be benign. It's been there for so long. It's kind of regular looking. And then we can use the location in the body, including in the foot, to understand what the differential might be for this. And so certain things are going to be more common in certain body parts. And so one of the more common things in the foot for a benign mass is a fibroma. And so we're going to be using that to kind of figure out what things are. So kind of an interesting case, I thought, with interesting imaging features. So case 9, this is a 68-year-old man with chronic renal disease and foot pain. These are two sagittal images of the hind foot and ankle. And the interesting thing here, so I want you guys to pause for a second and look at the signal abnormality here. So this is a T1 weighted image, and this is a STIR image. And so I think it's striking, if you stop to think about this for a second, you'd almost wonder if I flipped these. So this one on the right that's labeled STIR looks more like a T1 non-fat SAT to me. And the one on the left here looks maybe more like a STIR. It looks like it's saturated out. So you're going to then turn around and say, well, did you mislabel these? Or did the technologist mislabel them? Or did they run the wrong sequence? Or did something happen? And so you do all that, and it checks out that they didn't. This is actually what it was. So I don't know if you guys have seen this before, but this is basically diffuse abnormality and replacement here. Everything in the bones, the soft tissues is all replaced. So that's why you're getting so much high signal here on the STIR. Everything has high signal. So this is a case of serous atrophy, which is something maybe we don't see as much of. And so this is basically replacement of all the bone marrow and all of this fat with a kind of a gelatinous material. And this is seen in cases of malnutrition or really severe systemic disease where the body is basically mobilizing all of that fat and replacing that structure with like this like mucus-like gelatinous stuff that looks like this on the STIR. This usually occurs first in the like the distal extremities, like the hands and feet. You're going to see it more likely there first rather than centrally. So when we're imaging the foot like this, it's going to look like this rather than if you're looking more centrally or proximally, you're not going to see it as early. This can be reversible. So if you reverse the problem, if you're able to reverse the problem for the patient, this can all go back to normal. But this is a case of serous atrophy. So like we talked about this, so this is a sign of some kind of underlying problem and usually occurs distally first. So kind of a striking case. if you're used to looking at what the normal sequence is, what their appearance is. All right, we'll do case 10, and I'll pause for a minute after this next case, and then we'll see if there's any questions, and if not, we can do a few more. So case 10, this is a 21-year-old high jumper with foot pain. Here are the initial radiographs. And I would say, to me, and maybe I am not as sensitive as some readers, I don't really see a whole lot here. You're looking for something like a fracture, something like that, stress reaction. And I would say I really don't see it. Maybe you guys do, but I really don't see it. So we went on to MRI here because this person was having a lot of pain. Here are the the axial sequences here. So this is the T1 weighted and the STIR, and we see signal abnormality in the cuboid. So there's edema here on the STIR sequence and some patchy low signal. And in the middle of that, there's this linear low signal in the cuboid. So on both sequences. So this is a stress fracture of the cuboid. And here's another example of that. So when you're finding these things, these stress fractures, I know they're kind of straightforward. I think we don't always expect to see them in the metatarsals a lot of times. You can see them anywhere. Always look for that linear low signal. It should be in the epicenter of the edema. So if you're seeing what looks like linear low signal that's way outside of the edema, it's probably something else like a trabeculation or something else. So kind of be mindful of where you're localizing it in the edema. I think that can help sometimes if you're on the fence about what it is. And then someone once told me that we're talking about linear signal abnormality, and this is a nice example of one where it looks like a fracture line, but sometimes even with the fracture, it can look kind of smudgy or fuzzy, or sometimes even like a zigzag with an insufficiency fracture. So we want it to be roughly linear, keep that in mind, and you want it to be more linear than a mass. So use those as your guiding principles. All right, so that is a stress fracture of the cuboid, linear low signal. And then we're also going to look at bone mineralization. I'll just say this real quick. So this patient, the bone mineralization looks pretty good, but in these athletes where you're looking for stress reactions, sometimes you as the radiologist might be the first person to realize that some of these athletes might have low bone mineral density. And so it might be something you recommend in your report. If you think that the patient is osteopenic, you might want to make note of that, especially if it's a 20-year-old where they're doing some kind of performance sport. All right, I see one thing in the Q&A. Case 9. So this was, we can go back real quick to case 9. This was serous atrophy. So this is like a gelatinous replacement of the marrow. So it's not like red marrow reconversion. This is actually replacement of the fat with a different type of material, more of a gelatinous material. So red marrow reconversion, you'd see like that hematopoietic marrow signal. This is replacement with like an actual gelatinous substance that you see in really severe disease. All right. Any other questions? I'll pause for 1 second here before we do case 11. Okay, I'll show a few more. So I think we have a few more minutes together. So case 11, we've got a 22-year-old this time with foot pain for 3 months. Here are the radiographs. I would say on first glance here, looking at these like I would on a normal day, I'm not sure what I would see. If I knew the area of pain, I might see the finding a little more easily. If I was just told foot pain and there was no other information in the chart, I'm not sure that I would see this. But I'll point out there's a little area of kind of rounded sclerosis in the cuboid here. You can kind of see it here on the frontal radiograph. Here's the MRI for this patient. These are sagittal images of the hindfoot. And you can see in the cuboid, there's a lot of marrow edema, a patchy signal in the T1 weighted image. And there's this round focus here of low signal with a little tiny area of high signal in the middle. So as opposed to our last case where we're seeing linear signal abnormality, it looked like a fracture. Here we're seeing this rounded focus with a lot of edema. So we're thinking maybe now more about something like an osteoid osteoma with a nidus that we're seeing that's low signal. And then on the CT, we see this really sclerotic area with central clearing here and right in the same spot where we saw that on the MRI. So this was an osteoid osteoma of the cuboid. And you can see over here on this far right image, you can see that we're treating this with radiofrequency ablation. So we've put our biopsy device in. We take a biopsy of this first, and then we do the ablation, and that can really help patients. The thing to remember with these, I think, is sometimes these are very straightforward, and sometimes they can be more tricky. But if you see, if you have a history that goes along with it, and you see an area where there's really a lot of edema, more than just like a small kind of patchy area, you see a lot of edema, look closely for this, because it can sometimes be tricky to find the nidus, especially if this isn't suspected. So make sure you're looking for that, and kind of focusing in to make sure that you're not missing this. Sometimes it can be tricky to know whether this could be a cyst or something like that if it's near a joint, but a lot of times these are going to have really robust edema, and you want to be on the lookout, especially in younger patients like this. So a nice case of a cuboid osteoid osteoma. All right, we talked about that. So next case here, we have a radiograph of the forefoot. This was a patient with toe pain. And again, here, I would argue maybe not a lot that stands out on the radiograph. This person has great toe pain, and we're going to show the MRI next. So this is a case here. So we're zeroed in on the first MTP joint. We're looking here on the sagittal view, and we see underlying the first metatarsal head here in the region of the plantar plate, there's some irregularity. The low signal plantar plate here looks kind of irregular and almost kind of shredded. Here's the sesamoid here. On the coronal view over here on the right of the screen, we see the two hallux sesamoids here separated, and then the tendon underneath, and we see these look a little bit farther apart, I would say, than normal, and there's some soft tissue edema around that. So we're thinking now something about a plantar plate tear. This is kind of more of an axial view of this great toe region. We see the two hallux sesamoids here. There's some edema around it. Here's especially around the medial sesamoid. We see some irregularity in the region, the central region of the plantar plate. And then there's some signal abnormality too proximally. And I'll show you in 1 second. I think the plantar plate's a really hard structure to understand, especially if you haven't looked at a lot of them. So I'll show you some anatomy in a second, but this was an example of a plantar plate tear with some edema as well in this metatarsosesamoid ligament here. So the first MTP joint has a more complex anatomy than what they call the lesser MTP joints, which are 2nd through 5th. So because of the sesamoids, and on this joint, you have 2 sesamoids, and you have ligaments that are running from the metatarsal to the sesamoid and the sesamoid to the proximal phalanx. So you have that twice for both sesamoids. You have the plantar plate in the middle, which I'll show you a little bit better in a second. And then you have some other accessory ligaments, and you have a tendon running through. But the important thing to remember for you guys when you're looking for these injuries is you want this low signal, nice, regular, smooth central plantar plate when you're kind of in the middle of this joint. So I have an example of it over here. This is nice, low signal, regular central plate. The axial view here shows, here's a diagram. And again, this is complex anatomy. The idea is you have the 2 sesamoids. There's an intersesamoidal ligament. And then that central low signal area underneath that, this fibrous area, is the plantar plate. So here we're looking at it kind of from above and seeing this low signal area between the 2 sesamoids. So that's what you're wanting to see. And I think that sometimes that can be really hard to picture until you look at this anatomy a little bit. With the other MTP joints, 2nd through 5th, you're also looking for that low signal plantar plate here, but you don't have such a complex anatomy of ligaments because you don't usually have those sesamoids there with all the anatomy there. So that's what you're looking at for the 2nd through 5th. So again, complex anatomy, you're looking for irregularity and high signal, and then there is sometimes a normal recess. I'll go back here for a second. There's a normal recess at the end here that's kind of smooth and high signal, and that's just a normal structure. So, all right. So we are at about 7:40, and I want to be respectful of your guys' time. I know you have things to do tonight. I'm going to pause there and stop showing cases, and I will be glad to answer any questions. I see a few in the Q&A here, Tony.
Yeah, thank you, Kara. That was awesome. Let me sort through. We have a couple of questions here in the Q&A and then one in the chat. Let's start with this one here. It's about, in reference to the case of gout that you showed, how do you tell gout from infection?
I would say you're usually looking for, you can look at some of the imaging findings, and you got to look at the clinical history as well. So if you have a single joint that's involved, you're going to look up whether or not the clinical team is suspicious of infection. Is there an ulcer nearby? Is the patient having cellulitis and those kinds of changes, fevers, all those kinds of systemic things? Do they know if there's a high uric acid? Do they know some of those other inflammatory markers? And what do they think? What are they putting together for a clinical picture? Usually an infectious case in a foot is going to be as a result of an ulcer. There are, of course, patients who might have a systemic infection where you're including that in the differential. You're also looking for some, you would hope to maybe see some of those classic signs of gout, like a tophus in the soft tissues, erosions with an overhanging edge, as opposed to more of a destructive process of the entire joint that you might see with an infection. But you're kind of putting all those things together. And sometimes it's confounded. And like we always kind of say, you might have to aspirate the joint if there's fluid there to see if you're getting an infectious picture or crystals. Usually you're driven in one direction or the other ahead of time, but really ultimately the answer comes from a fluid sample if you can get it, if that's where you need to go. If it's still a confusing picture.
Yeah, I think that's those are all great points. And, as I tell my residents, you should never interpret cases in a vacuum, right? You always have to take the context of what's going on with the patient into consideration as you interpret the images and you make a diagnosis. And the other thing I would add is, and you also mentioned this, gout is a very long developing process, right? So those erosions will have those sclerotic margins because takes the body, the erosions develop over time, so your body has time to kind of react to it, and then builds up bone to try to heal the erosions, whereas infection is going to be less kind of more acute appearing in terms of the bone destruction. Other question here rather, in reference to the synovial sarcoma case, two questions, one initial one and then a follow-up. Great cases, Kara. For the synovial sarcoma case, it looked pretty homogeneous. I'm used to associating the triple sign with them. What's been your experience with seeing mostly homogeneous, somewhat slow-growing masses ultimately end up as synovial sarcomas? And then a follow-up to that is, if the patient had gotten an ultrasound after the first study, do you think it would have shown something sinister at that stage?
Excuse me, I think that's a great question. So as far as getting the ultrasound after the first one, what you'd be looking for would be internal vascularity in that lesion, that you could maybe show that it's a solid vascular lesion as opposed to a cyst. So I think potentially that could have helped us. We can see pretty small solid masses using ultrasound in a decent amount of detail. So, and that's a lot of times, the indication for an ultrasound for a lot of the things we look at is cyst versus solid. So I would think that would have potentially given us an answer. As far as looking at things that eventually become a synovial sarcoma, I think we tend to be conservative on looking at if something is enhancing and we think there's any chance that it's a solid mass. We're going to be trying to biopsy it, trying to figure out if it's something bad right away. So that's kind of our approach here. Is if we can't figure it out with the imaging that it looks like something that's clearly cystic and benign, we're going to be trying to get at it early. But it's the interesting part about this case is you don't see it often. Most of the time those little ditzels of fluid that you see in feet and ankles and other areas don't turn out to be anything. But we have to kind of check off all the boxes on all of those things that we think might be leading into something that's not a typical ganglion, or not a typical bursa or anything like that. So I guess that's my advice, is to go slow and be cautious as much as you can, if you can't make that diagnosis for sure. Tony, I don't know if you have thoughts on that either.
No, it's funny because I have a case also that is sort of almost the same exact case where patient came in. I forget what the clinical history or presentation was, but it was a very small mass, just like the one that you showed. And most people that, especially if you're going through quickly, you're not going to make much of it, right? Because as you said, we see so many of those things around in the feet, but also ended up not getting appropriate follow-up, ended up coming back sometime later, and at that point grew and became obvious that it was something that was more than a ganglion cyst, and also ended up being a synovial sarcoma. So yeah, it's you have to kind of, I think you made the points that you made were all excellent. Ganglion cysts should be, related to, the joints or tendon sheets. They should be arising from somewhere that makes sense. It shouldn't be sitting in the middle of, nowhere. And then, smaller synovial sarcomas, like you often pick up when you see them in the extremities, I think can be more homogeneous than the larger ones that have more of the heterogeneity and the necrosis and the calcifications that you can see. One last question here. Is that turf toe? So in reference to the later case that you showed, or how do you, I guess let's repurpose this question, and how do you describe turf toe, and what do you use that term in your reports? And
we don't use that in our reports in the actual impression, I would say. That sometimes comes in as the clinical history is turf toe. But we typically don't say that. I guess, that's kind of like, I think kind of a clinical term, or it's a phrase that's thrown around, kind of the mechanism of like stubbing your toe into the turf and having that that injury where you're kind of stretching the plantar plate region, but we're usually trying to describe as best we can the plantar plate and the structures around it. Sometimes you'll see on cases, you might have a little more clue on the radiographs if you see sesamoids displaced, and sometimes they will be if there's a significant ligamentous injury. You'll see sesamoids kind of out of place compared to each other along that first metatarsal. But we typically just are descriptive. We try to talk about as many of those structures as we can, and they can be hard, and they're small structures, and so we kind of sometimes wonder how much detail we're seeing. But we do our best. We look at them a little bit with ultrasound here, but most of the time with MRI. I don't know, Tony, if you have better tips than I do. I think those can be challenging cases.
Yeah, 100% agree. I mean, I think, turf toe is, like you said, something that we often may get as the clinical history, especially if you're dealing with an athlete that had an acute injury at some point during the game. But in terms of interpretation and what we see on imaging, it's definitely better to, like you said, talk about the specific structure that's injured. So because that anatomy there, as you referenced, is so complex and different than the lesser metatarsal phalangeal joints, if it's an injury to that area, you know, I generally say, is it a sesamoid injury? Is it a metatarsal phalangeal ligament injury? Is it a sesamoid phalangeal injury? So specify which structures, and if there's more than one, list the structures that are injured rather than just kind of calling it a single kind of term as a turf toe.
Yeah.
All right, so I think that brings us to the conclusion there. I don't see any more questions in the Q&A. Again, thank you, Kara. Really great cases, excellent review. I think it was great that you brought up a lot of real life scenarios that and challenges that we deal with as radiologists. So these are interesting cases, but they're also kind of real cases that and real difficulties that we face every day. Please, everyone, give us your feedback about the session. The link has been posted to the chat box. You can access it there. For those of you that have registered, you will also receive the link via email. So please let us know what you think. And that brings the session to a close. Please, everyone, join us again next month, May 15th at 7 p.m. For the next lecture of the series, which will be Interesting Muscle Cases, presented by Dr. Eddie Smedeman from UCSD. Thank you again for joining us, and I hope everyone has a good night.
Thanks, everybody.